a 68-year-old female presents with progressive thigh pain and swelling. I am showing you a lateral femur radiograph, sagittal post-contrast magnetic resonance image, axial computed tomography of the femur, and axial chest computed tomography. Please describe the findings.
The femur radiograph demonstrates a concave cortical erosion in the anterior distal femoral diaphysis with periosteal reaction. The femur computed tomography and magnetic resonance images confirm focal cortical destruction with an invading, enhancing soft tissue mass and surrounding marrow edema, while the chest computed tomography reveals a parahilar mass.
What is your primary diagnostic concern?
The findings of a focal, concave cortical bone erosion in the diaphysis of a long bone, combined with a parahilar lung mass, are highly diagnostic of a cortical metastasis from primary bronchogenic carcinoma.
What is the classic radiographic term used for this type of cortical erosion, and which primary tumors most commonly cause it?
This is known as the cookie bite sign. It is classically associated with bronchogenic carcinoma, but can also arise from renal cell carcinoma, breast cancer, melanoma, or epidermoid carcinoma metastases.
Why is a cortical metastasis less common than a medullary metastasis in the skeleton?
It is less common because hematogenous metastasis typically targets areas of high vascularity, which are the red marrow-rich medullary cavities of the axial skeleton rather than the cortical bone.
What is the differential diagnosis for a solitary, superficial, cortical lytic bone lesion on radiographs?
Differentials include subacute osteomyelitis, a periosteal or peristeal osteosarcoma, and a foreign body granuloma. Osteomyelitis is distinguished by clinical infection signs, while surface osteosarcomas show malignant osteoid matrix.
How do computed tomography and magnetic resonance imaging help in the evaluation of a cookie bite lesion?
They are utilized to precisely delineate the extent of cortical bone destruction, visualize the soft tissue mass size, identify intraosseous marrow edema, and assist in planning an image-guided biopsy.
What is the clinical significance of detecting a cortical metastasis in terms of staging and patient management?
It indicates stage 4 advanced metastatic disease. This shifts patient management from local curative therapies towards systemic medical therapy and palliative care, such as local radiation for pain control.
Finally, what are your immediate clinical recommendations for this patient?
I recommend a computed tomography guided biopsy of the femoral mass to confirm metastatic disease and lung origin, along with referral to oncology for systemic therapy. We must also evaluate the femur for prophylactic surgical stabilization if there is a high fracture risk.